Hello, hello, everyone. I am so happy that you decided to join me today. And I have a very special guest to talk about a very relevant topic that we're actually hearing quite a lot about in the news today. And I'm so grateful that Julie Beem, who's the executive director of the Attachment and Trauma Network, is with us today. And I would love to hear more about your organization. I'm so excited to have this conversation with you. It's such a relevant topic. And as you know, I talk as it relates to developmental disabilities, but we just want an overview. There's so much to learn in the arena of trauma. So tell us a little bit about your organization, Julie.
Sure. Thank you, Rita. I'm thrilled to be here with you today. So the Attachment and Trauma Network is 26 years old, founded in 1995 by a group of parents, because parents are so powerful in this type of work, they were brought together by their common therapist who was helping them with their children who were struggling with what they knew in those days to be attachment disorder. So they banded together to try to support each other and learn more about what attachment disorder was, what the parenting strategies would be, what was needed, and started pulling in speakers. This was in Kansas City, Missouri. They started pulling in speakers from all over the country, to pay them to come and give a webinar, or it wasn't a webinar, it was a live presentation in 1995. And before long, other families started finding them and calling them on the phone, and then eventually emailing them. And as the internet grew, there was more of a support. And as the brain science grew, what happened on the research side and on the technical side was the understanding that children who struggle with their early attachments are children who've been impacted by trauma. So I discovered this group of parents and clinicians about 2000, when I had brought my daughter home from China in 1998, and she was the fourth child in our family, and we could tell as a 2-year-old that there was a lot going on there, but we couldn't seem to get professionals to help us ferret that out. It was developmental, but it wasn't necessarily fitting into the developmental categories and disabilities that are typical. Mm-hmm. And they kept saying, no, it's not autism. No, it's not this. No, it's not that. Just wait and see what happens. And her behaviors and what I now know to be dysregulation was so significant that I was needing somebody to support me in some way. So I found these folks. They were highly supportive. They were highly educated in this world and pointed me to a lot of really good therapeutic resources and concepts. And so I turned and started volunteering with them. And when in 2007, we actually made the name change shift from Attachment Disorder Network to Attachment and Trauma Network to reflect that whole shift of the understanding of how trauma was impacting children, especially relational trauma, and how it impacts children early on in terms of their ability to attach. And now we know so much more of their ability to focus and learn and all of those things. And so when the founding person decided that she was going to retire, she asked me if I would step in as the executive director, which was a huge honor and came with a zero paycheck, but there you go, right? So I did that, and I have held that position since 2009. And since 2009, the past the decade of the brain, past the advents of neurobiology and understanding way more about what happens to us when we are traumatized, when we are under traumatic stress. There's just been a huge influx of opportunities for ATN. And one of the things that we added was a program for schools and educators. And that is, we started that in about 2014, had our first national conference in 2018. And it's just, it's much larger than our parenting program. Our parenting program is really the core, and where a lot of our hearts are working with parents and families and making sure that they get access to resources and the support that they need. But we're thrilled of what educators actually are taking this mantle and pushing the idea of trauma-informed education forward, as well as different community groups are doing the same. So
you're really at the forefront. I mean, 20 years in, right? Almost.
Yeah,
but still at the forefront.
All trauma all the time for more than 2 decades at this point.
And now it's a hot topic. Yeah.
Right. So glad that the rest of you joined us. It's
right,
really
right. And I just want to point out and highlight the power of parents, right? Because it was parents that came together and how important that is. And by the way, Julie and I met through a program called Partners in Policymaking, again, which brings parents together. So I just wanted to highlight that, how important it is, and that we're not just a parent,
Exactly.
It's so much more powerful than that. And parents never give up. That's another thing about us, is we never give up.
Such a tenacious, passionate group. And my board has parents on it. My board actually has adult survivors of trauma on it who bring a very powerful voice to what it is that we do. So I get up every day thrilled to work in the passion of this work.
So when we talk about trauma, I was driving in my neighborhood, and I think it was yesterday, and I saw, you see those signs that say trauma, which means to the hospital. That's not the trauma that we're talking about, right? So tell us about what is trauma, and from your perspective, how can we define it?
The best definition that I know is that it is that trauma is caused by an event or a situation where your body's physiology, not just your emotions, but your body's physiology feels helpless and hopeless. And the reason that I say that is that there are with that comes a lot of different information about trauma. First of all, we're talking about the feeling and also the neurology of what happens in that feeling of being helpless and hopeless. And it also then leads us to understanding that what traumatizes me isn't necessarily what traumatizes you, right? So we can survive the same thing, like take a car accident, for example. We can be in the same car accident, we can be in the same car, and I might have long-lasting neurological differences in terms of how my physiology manifests itself than you do. I mean, that for me,
do we know why? Do we know why that is?
We don't really know why that is. There is a slight genetic component, they believe, but a lot of it has to do with environmentally what happened to us early on. More and more of the science is pointing to the criticalness of what happens to our nervous systems as infants and how our needs are met, or how we perceive our needs are met. So if I'm a child who did not get what the researchers actually call good enough parenting, I'm at risk. If I'm a child who maybe my family had some hardships at the early beginnings and maybe I had shifted caregivers, I'm at risk. If I'm a child that maybe had to have a lot of medical procedures when I was really, really tiny, and so I had pain that I couldn't necessarily express, and therefore it wasn't really taken away, or they couldn't take it away, I'm at risk of having what we talk about our children as having their thermostat set a little high. So my baseline of being more likely to react and have a traumatic reaction to, and a traumatic, stress from a situation is just I'm at a higher risk for that. Okay. Does that make sense?
Yeah, it does. It does. So, and I love the thermostat metaphor. So trauma is not the actual event. It's the how that event affects us, right? It's the
Yes.
imprint on our
Yes.
brain and our physiology.
Right. And then that causes us to be dysregulated. And you hear the words fight, flight, or freeze used in terms of your reaction to a trauma. And that causes us to go into that, and also then causes us to carry that fight, flight, or freeze behavior into other situations where our physiology is triggered. So that we can, I mean, it's easier to see, like with a military veteran, that, in a situation where where fireworks, for example, would have a physiological reaction to, hearing the boom of the fireworks, and, and it's not just that they are afraid; they actually have that reaction. Their blood pressure goes up, their heart races, all of those things can happen. And then the behaviors that that come on from that. And sometimes you can see how this gets really tricky, because a lot of times people have a reaction to a trigger that you don't even know what that is necessarily.
But it's very real for them.
It's very real for them. It is not just a willful misbehavior or a big emotion. It's going on inside of their nervous system. And unless they have tools with which to calm their nervous system down, it's very difficult for them to be in the moment.
And that's why your work with schools and teachers is so important, for them to be able to have that understanding and compassion, because so much of the time it's there's not the understanding. It's not there yet.
Right. Well, and the other piece of that is how prevalent this adversity and these early childhood traumas really are. And until you know that, you're just thinking this is a small subset of people who've been in a war situation, people who've been abused. Well, actually, the Adverse Childhood Experiences study that was done by the CDC in conjunction with Kaiser Permanente back in the late 90s, and then has been replicated over and over and over again, shows that adverse childhood experiences, they call them ACEs, are much more common than we realize, and that 60% of our population has at least one of them. And they did this whole study it's pretty interesting to look into the history of it, and I won't bore you with all of it, but they were looking for why women were overweight and having trouble with weight loss. So it was primarily middle-class white women that they studied at the beginning, and they started asking them questions about their childhood. And what they found was that these women who had one of these ACEs, which was everything from loss of caregiver to somebody with mental illness in their family to I'm trying to think there's 10 of them. Divorce, somebody that was incarcerated. I'm sorry that I'm not pulling up all 10.
That's all right.
But the point is that the women with the higher ACE scores were much more likely to struggle in losing weight. Then they started doing other studies, other epidemiology studies using the same 10 ACEs criteria, and found out that people are at risk for all kinds of behaviors, addiction behaviors and risky behaviors, and and not graduating school and all of these different things. And then they're also at risk for physical illnesses, cancer, heart disease, all of these things. So it's started down the trajectory of why are those two things married, and now almost every state in the country, Georgia has done it 3 times, has conducted an ACEs study with very similar results. And what we know is that 60% of the population has at least one ACE. And if you get to that 3 or 4 ACEs group, those people are significantly at risk for a lot of those things. And if you get up into the 7 and 8 and 9 area, it's even more so. But about 20 to 25% of any classroom across the country regardless of the makeup of that classroom, regardless of the makeup of that school, has 3 or 4 ACEs. So in every classroom, there's 20% of the population who've been impacted by trauma enough that it can impact their learning. So that's what's so critical that teachers understand, is that piece right there. We're not just talking about children who have developmental issues. We're not just talking about children who qualify for special ed, or children who have been in a very poverty-ridden situation. We're talking about all children across that there's about 20%. Now, obviously, some classrooms have got even higher than that. So it's really important that we understand what trauma does to our brains and what we need to do in response to that.
So it sounds like trauma, it affects not only our brains but our bodies as well.
Yes.
And as you said, it could also affect level of education completed and other factors as well. So those are some of the larger picture effects of trauma. Are there specific things that we could perhaps look for? Are there things like that you would consider as symptoms or anything like that could help describe someone that maybe has gone through a traumatic event or situation? And does that come on immediately, or can it come on years later or months and years later?
But actually, it can do either one. I mean, it's that the concept of trauma really is. I mean, it's a basic understanding, but there's a lot of complexity because each one of us is so individualized in the way that our nervous system works and in the way that we manifest things. So it can be that symptoms come on later. What we generally see are symptoms that fall into either fight, flight, or freeze in terms of what they look like. Fight being, aggression and opposition, and I mean that what in a classroom a child who's exhibiting that, it's often while they're being aggressive, they're being manipulative, they're being defiant, they're being disrespectful. Those would be words that you would use around the behaviors that you might see for a child who was trying to fight their way out of their trauma response. The flight folks could be that they are even lazy and daydreaming, and same way with the freeze. The freeze is definitely the child is checking out and shutting down, and in a lot of classroom situations, a freeze child, especially if their behaviors are not atypical the rest of the time, a lot of that is missed, right? They just, he's just not quite applying himself enough. There's just not, it's overlooked a lot because you don't see somebody checking out and zoning out.
Right, because they're still considered compliant, right?
Right.
Following along, yeah.
Right, exactly. And so all of those things can happen. It can be all of those kinds of things. What you normally, when you see the trauma, the language behind that and what you normally see is what's called a dysregulation, right? Where your nervous system is not regulated. And we adults get dysregulated too all the time. I mean, all of us have that. So part of the strategy of what we teach parents and what we teach educators is around the idea of actively helping children learn how to know when they are starting to get dysregulated and what they can do to regulate themselves, what tools are available to them. And it's that active teaching that is so incredibly powerful. And it blew my mind, actually, because I have 3 non-traumatized, very typical children that I didn't have to actively teach them how to regulate. They learned that actually as infants. I mean, that's one of the that's where you learn it, is
Right.
that when your needs
Your
are met
caregiver,
over
yeah.
and over again, your caregiver, then you internalize that, and you don't have to have the skill set built. But when you don't get that, and or when you can't access it because of the traumas that have gotten in the way, concrete learning of how to use tools to regulate you, whether tools like breathing and movement and humor and sensory input and all of the things that will help you and be able to use those when you need them.
So
Is
these are
really
not
helpful.
expensive tools. These are things that are
No.
readily available to everyone. And I like that you talked about teaching, and it's also a practice, right? So it's
Yes.
not learning at once,
Yes.
it's being proactive and practicing those
Right.
skills as well.
Right. So if you're in a trauma-informed classroom, what you notice about that is the availability of those tools and the permission and guidance to use the tools when necessary. They're not done as rewards. It's like, oh, well, you can have your sensory tool because you got your math lesson done. That's not it. When you need it, you use it. The same way that adults we all have regulation tools. I'm a huge pen clicker. My staff is like always, oh, you're clicking the pen on Zoom again. That's my thing, right?
Yeah.
And I just do that. Everybody's got something that they're doing. They chew gum, they do whatever it is. So nobody stops us from doing that and says, well, you got to get your work day done before you can click your pen. So the same thing applies to children. Teach them, let them then find out what they gravitate towards and help them learn to use that when they start to feel dysregulated. So there's a lot of that going on in the classroom. And there's an awareness of what's called co-regulation. So when a child, especially because their nervous systems are still developing, right? When they get overwhelmed with the big feelings that are coming up and they can't regulate, sometimes they also can't use the tools, right? You're just like, go get the squishy ball. So what they need is a co-regulator, a person, an adult who's able to stay regulated to help, if you will, give them a piece of that regulation. Because one of the really cool things about the science is how social and relational our nervous systems are, and how important it is for us to use that social, relational connectedness to help each other regulate.
So if an adult is maybe not aware of this, if their reaction becomes bigger than that child's reaction,
yes,
then that child will never learn, right?
Right.
How to self-regulate.
And actually that child will probably be very afraid. I mean, because if you're going to have a connection with somebody, if you're going to have a relationship, the first thing that breaks that down really fast is fear, right? So if I'm afraid of you, you and I are not going to be able to have a relationship, and because you're bigger and stronger than I am as an adult, it's even more so. So if the adult isn't calm, or can't get calm, and sometimes we can't because some child's behavior is really triggering to us. I mean, I don't like children yelling cuss words at me, right? So if they yell a cuss word at me and I'm having a rough day, there's a chance that my own nervous system is going to be heightened at that point. And I am probably not the best person to help them calm down if I'm already, up in that whole red zone myself, right? If I'm already, about to flip my own lid, as Dr. Dan Siegel would say, I need to get my own self together before I can be somebody that they can regulate with. So there has to be an awareness of that. There has to be an awareness of what's going on inside ourselves as the adults, and then a plan for if we are dysregulated and we need to go do our own work, what's going to happen in that situation. Right.
So we've talked a lot about children. Is it ever too late to heal trauma?
No, it is not. I mean, and I know that there are some people out there that probably, even clinicians, that are shaking their head going, she may be wrong on that. But I know too many success stories to not believe that fully. At the same time, it's just like all other brain development. It's much easier to heal and make healing progress when you're young, when your brain is young and flexible, than it is the older that you get. Because just like anything else that has to do with our bodies, really, but definitely with our brains, it's about repetition, right? If you're going to change anything, you have to repeat what it is you want to change to over and over and over again. And the same is true with people who are impacted by trauma. The other two things I want to say about that is that it depends on the level of trauma and the chronicness of it. Both how severe it is and how long you've had your traumatic stress. Like if it's been since birth and early childhood, that's going to be a harder trajectory, and that's going to be much more developmental in the way that it impacts so many parts of who you are. So it's going to be a harder thing than if it stems from incidents that happened when you were older.
Okay.
Yeah.
What about from the lens of developmental disabilities? And I'm just editorializing here and thinking out loud, but are individuals with developmental disabilities such as autism, Down syndrome, etc., can experience trauma as well, trauma from a system, say a school system maybe that doesn't understand them, from a system of care, a medical system. So there are a lot of potential events there that can cause trauma. Has there been any type of study with individuals with developmental disabilities and reactions to trauma, or is there such a study that exists?
I'm going to tell you, Rita, that I'm not aware of specific research on that.
Okay.
But there needs to be, because there are many more voices from the autism community talking about the level of trauma that people with autism have reported as adults, either things that have happened to them as children through school or through different kinds of therapy practices that became more coercive. All of those kinds of things that can happen. And there's no reason to believe that somebody who has developmental disabilities, that their nervous system would respond any different than the rest of us in terms of picking up traumatic stress and struggling with that. And I would think that it would manifest itself in similar behaviors, but it might be so confused because of the other behaviors and ways that those disabilities manifest themselves.
So we're talking about, especially individuals on the autism spectrum who probably have a more sensitive nervous system to begin with. Yeah.
Right. They may not, it would be harder for them to express what it was that they were feeling, and they may not be able to pick up the relational cues of safety and co-regulation in the same ways that people who do not have autism have it, are able to do that. So even helping them walk through the steps of healing is probably going to be tougher because of that, of their, it's going to take people that they already trust. It's going to take a lot of extra focus on making sure that they are interpreting the messages that are being sent to them, and that there's a constant communication of what that is like for them.
And I love that you said that we really need to listen to self-advocates, our adults with autism, because they are the ones that are, the ones that can tell us. And I believe everyone can communicate in some way, shape, or form, but we need to do more listening in order to, again, learn about their experiences, what caused the trauma, to help kids in the future.
Yes, exactly. Right.
Yeah.
Well, and then the other thing I wanted to focus in on was around the word healing. One of the things that we know really distinctly from talking to people who have survived trauma and have significantly healed from trauma is that our expectation of healing doesn't mean curing. So it's like once you've been impacted by trauma, it's not like you're ever going to not be impacted by trauma. It's more like a wound that has a scab and then scar tissue to it. You might, it's never going to be as if it hadn't happened for you. It's always going to be, be there and have a potential to impact your, the way that your system regulates or the way that you approach things. It's much more about your own self-awareness and self-ability to navigate that, to know if it's starting to happen, to know what to do about it, to know how, where to go for help, those types of things.
So more managing then.
Yes.
Right? Managing symptoms.
And, when I talk to people, obviously there are simple traumas. Like I had a traumatic experience in a car accident. So I don't really have tons of impact from that because it was during when we were treating my daughter. So I actually did EMDR. I actually did a trauma therapy for that. And don't have a lot of impact from that unless we get into a near miss situation. I don't really feel, there's not a whole lot of big emotion or dysregulation around that. But people who've had significant trauma early on say, it's part of who I am at this point, and I just have to, learn to navigate life differently. I have to learn to be aware of there are certain things I should or shouldn't do, can or cannot, experience. I have to be aware of, what might possibly be a trigger. And then I have to address it. And sometimes just addressing it and saying, excusing themselves, like hanging out with adults, watching how they navigate this, excusing themselves from a situation that they know is about to get triggering for them, or something along those lines. It's something that needs to be managed.
And does medication play a role in that management? Possibly.
It can. You have to remember that there is no medication that treats trauma, but there's medication that treats anxiety. There's medication that treats inattentiveness. There's, all of those different things. The tricky part is figuring out which medication to use, because depending on how your brain has responded to this, a lot of, especially going back to children will look really inattentive when they're really what we would call hypervigilant. So they might be sitting in a classroom, not paying attention, but they're really watching to see, is somebody going to come through that door? Are we still going to be safe? When is that bell going to ring that I have this huge sensory response to? Like all of the unknowns. And so it looks like they're not paying any attention. And so then we put them on a stimulant medication because we think they have ADHD. And that sometimes is very counter what their brain needs, and may actually make them more hypervigilant because now they're stimulated on top of, so their anxiety level, it's the same manifestation would be if you had diagnosed them with an anxiety disorder and put them on a stimulant. They would, in many cases, struggle with that as well. It's the opposite of what their brain
So we have to be really careful and monitor side effects, etc. Yeah, because it takes a lot of energy, I would imagine, if you're in that hypervigilant state all the time.
Right.
Yeah. And
to
trying to mask it. Yeah,
to stay any focus at all. And often what happens, and this happened for my daughter, and I've had talked to a ton of other folks that the same way, is that in the early part of their school day, they can kind of hold it together. But the longer the school day goes on and the more insults they have, either sensory, if that's their issue, or whatever else happens, and that hypervigilance, it's hard for them to hold it together. Or they hold it together and then they completely melt down when they get home because they've been working so very hard to try to stay focused and to try to not manifest any of that dysregulation, that they just can't do it anymore.
And so all of that is invisible, right? It's going on the inside. We can't see that. Yeah.
Right.
Yeah. Well, this has been a fascinating conversation. I think I could go on for probably another half an hour or so, but if people want to learn more about your organization, Julie, and more about childhood trauma, are there any authors that you recommend? How
Sure.
can we connect more with your work?
Sure. Well, you can connect directly with us at our website, attachedtrauma.org. And we have a podcast, and the goal of our podcast is just to talk about the issues related to trauma, and especially to relational trauma, and where attachment fits in that. Like why is attachment in our name? So we talk about those issues on the podcast. As far as authors, I would recommend the world should read Dr. Bruce Perry, and Oprah's new book. I've got it sitting on the shelf.
Yeah.
It's always within here it is.
Okay.
There you go.
Okay. What happened to you? Okay.
And if you're not a reader, that's even better. Go get the audio version, because it's Dr. Perry and Oprah just having a conversation. And it's so made for just understanding the overall impact of trauma on all of us as a society. So that's a good place to start. I'm a giant fan of Dr. Bessel van der Kolk. His book, The Body Keeps the Score, is a great way to learn the physiology, the neurobiology piece. If you're a parent, looking into the work by Dr. Dan Siegel is really important as well. We have within our website a store area, and the store area has a specific link to a bookstore where we have put everything that we find that we think is really great. And we've got it segmented by general knowledge about trauma, general knowledge about attachment, and then things for parents, things for educators, things for children. So, I'd encourage you to go there as well and look and see.
Well, thank you so much, Julie. I am so happy that the technology cooperated today. My lighting popped off, but other than that, I have nothing to complain about. And this has been a fantastic conversation. Thank you so much for this time together, and thank you for the work that you do. And everybody, take good care. Thank you so much, Julie.
Thanks,
all right,
Rita.
bye-bye.